So welcome everybody. So we have a record turnout here, and I wasn't sure, we're doing things a little differently for those who attend this meeting on a regular basis. So we've got the Zoom that allows us to have this panel. And Counts, you want to introduce Greg, and then we'll go from there.
Yeah, so I think most people should recognize most of the names on the screen, but Greg Friese might be a new one to a few of you. He's actually the editorial director for Lexipol, which is the umbrella organization over EMS1.com and Fire Rescue 1. And so we've invited him because I think he has a really good perspective of kind of some of the questions that maybe the rest of us at the academic level aren't always thinking about when it comes to vaccines and hesitation, and just generally what people are wondering and asking, kind of hoping for him to bounce ideas off of us and just make sure we're answering all the questions as comprehensively as possible.
Thanks for the introduction. Glad to be here. I'm actually at my home office in Wisconsin. Of course, if I could be at Grand Rounds, I would have offered to bring cheese curds or something real Wisconsin-like for everyone to enjoy.
You know, you have, you know, so Greg, I think we'll ask you to make sure that we're like getting the right questions asked. And part of the purpose of this is to help everybody understand about the vaccines and what's out there, and try to deal with understandable folks, the understandable concerns, I should say, of people who maybe wonder like, well, is this actually safe? Is this wise? So we'll call upon you to help us with that part of the conversation, okay? All right, with that, I think the basic plan here is I will give just a brief overview of the pieces of the puzzle that I made yesterday before this additional news came from Moderna, and then Dr. Ray can fill in with that part. So most of us are well aware that the pandemic continues here in Seattle and King County. This data from our community testing sites, and depending on where you are in the county, your mileage varies a bit on how likely it is you're going to have COVID if you show up at one of these testing sites. But overall, things are kind of at record highs. And we now have these 2 vaccines that are in development and are ready to launch. So the Pfizer one got authorized last Friday and is now shipped and is in people's arms in a few places across the country. And the Moderna vaccine is close behind. And I view this as a total home run, right? I mean, we have 2 vaccines now that are either launching or soon to launch that seem to be amazingly effective against COVID-19 disease. And a year ago, we didn't even know this disease existed. And here we are with working vaccines. So that's pretty phenomenal. There are other vaccines that are close behind, and I suspect we're going to have more choices in a few months compared to what we have even now. So a couple things that I think people maybe don't really understand really well, but it's super important, is no corners were cut in developing these vaccines. These vaccines have been held to the same safety standards as any other vaccine or any other medicine. The main difference is things happened in parallel, running together, as opposed to 1, then 2, then 3, then 4, then 5, then 6 steps that you would take to develop a new vaccine. So a lot of money got spent to make that happen, but it was an important problem, and that's why this has occurred so rapidly. Plus, we just had better science. So quick refresher on basically how messenger RNA vaccine works. And this is Moderna's slide, but the Pfizer vaccine is essentially the same. You have this, I heard this described this morning as a bubble, a fat bubble. And inside this small, tiny fat bubble is messenger RNA. And these things are microscopic, this bubble. And these bubbles get injected into a muscle, in this case, the deltoid muscle in your arm. And that bubble then is bound to the cell and releases its messenger RNA into the cell. And the cell's normal machinery does what it does every day. and produces proteins. So this messenger RNA is code that says, hey, make this protein. There's a really interesting article recently about how Pfizer tried, or the BioNTech people really tried 10 different messenger RNAs before settling on the one that actually is in use. So there was a whole process there, and they didn't do them one at a time. They did all 10 at once, and eventually narrowed it down to the one version of this messenger RNA that they actually have in their vaccine. So once this protein is made, in this case, the spike protein only of the COVID-19 or the SARS-CoV-2 virus, that is made in a large quantity and results in the muscle cells that normally would not have this protein, shedding that protein, expressing the protein on the surface that generates an antibody response. And that's, in a nutshell, how these things work. This then results in B cells, B lymphocytes that make antibodies, and T cells that are part of the immune response that basically eats things. And all that is ready to go then if somebody gets exposed to COVID. We've heard quite a bit about the challenges of storing vaccine A, which is the Pfizer-BioNTech vaccine. The big advantage for us in EMS with the Moderna vaccine is it doesn't require nearly the same degree of cold chain that the Pfizer-BioNTech vaccine does. It seems to be, at least today, maybe a little easier to use. We'll see if the Pfizer vaccine keeps this really rigorous cold. But I think that's a big advantage to the Moderna vaccine for places outside of hospitals. In a hospital where they have the ice, the dry ice, and they have the big deep freezers, the Pfizer vaccine is great, but in a more mobile situation, the Moderna vaccine might have big advantages. This was the last allocation I saw from the state of Washington. I haven't seen any updated numbers. It's likely they have been updated, but this was from about 10 days ago. So we can expect when the Pfizer vaccine is now in this week, or in this week, so next week we'll get a little bit more Pfizer doses, and hopefully next week we'll get a big slug of Moderna doses as well delivered to facilities in Washington. So the big question that's been in everybody's mind is who gets vaccinated first, and this works through this group at the Centers for Disease Control called the Advisory Committee on Immunization Practices. This group has representatives from the University of Washington and then work groups that then inform this larger committee, and there's people from Washington also working or seated on those work groups. And in the initial round, we're prioritizing healthcare personnel and, importantly, residents in long-term care facilities and the workers in those long-term care facilities. So this represents about 3 million Americans in these long-term care facilities and about 21 million Americans who are healthcare personnel. And that includes EMS workers. So EMTs and paramedics are included in this 21 million. As well as the workers who work in these long-term care facilities. So this is super important, I think, for reducing the number of deaths. Somewhere, depending on where you are, somewhere between a third and half of the deaths in most of the states come from residents of these long-term care facilities. And if we can get in and vaccinate these 3 million people, plus the workers in those places that are delivering supplies and medicines and so on to these patients, but sometimes also delivering COVID, I think we can make a huge difference in reducing the number of people who are dying and the stress on the healthcare system. So I worked last night in Harborview. We got a transfer of a patient from a long-term care facility, was diagnosed with COVID 3 days ago, and then he's getting worse, so now he had to be hospitalized. And that's just one more patient added to the many other patients that are in the hospital. So I think this will be really important as this takes effect in reducing the burden on our healthcare system. So this works out to about 33,000 people in long-term care facilities in Washington. And in Washington, long-term care facilities account for about half of the deaths. And in other communities, other states, it's similar and some are less, but you can see it's really a big burden on how many people are dying that we can make a big impact on with a relatively modest number of vaccinations. On the other hand, healthcare workers are roughly about 400,000 and then another 17,000 EMS in Washington state. So we are getting almost enough vaccine delivered to us by the end of December to get the initial dose in most of these people's arms if they're willing to go and get vaccinated. So these next set of slides are from the CDC. And so I think most of you on this webinar are in healthcare, your EMS, your flight nurses, et cetera. And so the rationale for having you be first in line, even though your personal risk of death if you get the disease is substantially lower than it is in a nursing home resident, is that you do have some increased risk of exposure, and importantly, you have the potential to transmit the disease to others who are higher risk than you are. So by vaccinating you as a worker in a healthcare setting, we're reducing the risk that you're going to give it to somebody who's 80 that you might be taken care of and not realize that you have COVID. But understandably, you might have a lot of questions about this vaccine. So we've talked about the Pfizer vaccine that's was manufactured by Pfizer, and the original technology is from BioNTech. So these are 2 doses that are given 21 days apart. The Moderna vaccine is also 2 doses, in this case, 28 days apart. So very similar, slight difference there, but very similar. Both of these vaccines have been tested in many thousands of adults from diverse backgrounds, and they both seem to be safe and effective. Key point, though, is we don't really know how long this protection is going to last. So this is just kind of the big picture in terms of the numbers. The vaccine trials were 50-50, so half the people got the active vaccine, the other half got saline, saltwater. And they included a large number of people who were older, so that's very important, as that's who's dying from this. We went over briefly, just a quick refresher. They're teaching the cells, they're instructing the cell how to make the spike protein, which is not the whole virus. It's just the one piece of the virus. The rest of the instructions are not there. So it's not making any virus. Therefore, getting vaccinated cannot make you infected with COVID-19 because you're not getting the whole virus. You're only getting the one piece. And importantly, the nucleus of your cells that contains your DNA is also not getting exposed. The RNA is a one-way street, goes from the nucleus of the cell out of the nucleus into the rest of the cell, but the messenger RNA does not go back into the nucleus. So it doesn't change your DNA or interact with your DNA. Now, part of what happens here is you get 2 doses. So after the first dose, your arm's sore maybe a little bit, and it's not too bad. But after the second dose, a reasonable number of people in the Pfizer trial was about 15% had a fever, and like 3/4 of people got a pretty sore arm. So while these were uncomfortable, they're not serious side effects. In the sense that, they're very short-term, self-limited, they get better on their own. And they really indicate that your immune system is kicking in and working. This is showing that your body is reacting to this vaccine. It's releasing some of the chemical signals, the cytokines that cause your body to react to any other kind of infection, which is why you feel like this. But it's actually good news. I mean, nobody wants to feel this way, but it's good news because it shows that the vaccine is taking and causing an immune response. We covered this as well, and this, just to reiterate, no corners were cut. It's just that things happened in parallel instead of sequentially. And this new technology, the messenger RNA vaccine technology, is just easier to manufacture and produce. So that's also helped get things out the door faster than otherwise would have happened. Okay, so There are a couple things that are happening. We talked about how the Immunization Practices Committee is reviewing data, and they're independent group of experts. They're not getting paid by drug companies. They're not being paid by the government. They're independent. They make recommendations. And then there's a whole system that's monitoring afterwards. So the vaccine adverse event reporting system is a key new piece, and they're having an app for that. So when you get vaccinated, I should say, hopefully you will, at some point, you have the option, you don't have to, but you can download this app, and then you can report into the CDC with any concerns that you might have about this. If you're concerned you might have a side effect, they're going to track these and look to see what's going on. So,
Dr. Sayre, on
Yeah.
that app, do you know if it's like in real time you can talk to somebody and like they give you like a nurse advice line, or is it just you, like it's a one-way direction of communication?
I haven't seen it, so I don't know for sure. Maybe somebody else knows. My understanding is you're basically doing a report, and if they find what you said super interesting, they're going to call you, basically.
Dr. Sayre, the side effects that you described, fever, headache, I think a lot of what I receive from the community isn't sort of those what we might term mild side effects, but sort of worries about worst case scenarios of, that might be years into the future, and then the pushback is like, well, until we know what the side effects are in 5, 10, 20 years, there's no way that I'm going to do this. And so how do you work with that concern that people have about the difference between short-term and long-term side effects?
I agree. That's a very important question. Dr. Ray, do you want to take a stab at that?
Sure. Yeah, no, I agree. It's good to have these questions. So I think a couple of points to address. One is that we know from all prior vaccination activities, whether it's for measles or polio or what have you, that the vast majority of symptoms and adverse side effects occur within the first days and weeks following the vaccine. So the reports coming back to the FDA and being independently reviewed involve the first 8 and sometimes 12 weeks of experience after the vaccine. So, they have covered the large majority of time during which these things can occur. The second point is one of biology, right? So we've been studying mRNA for decades, and it has been evaluated for many years, and we understand exactly how it works in our bodies. And if the biology holds, and we have every reason to believe it will, the reality that something could happen, years downstream is just, it's not a reality. Again, the biology is the biology, and the investigators have understood this when they designed the vaccine. So those are my 2 responses. Of course, we haven't followed anybody for 5 or 10 years. And so there is some uncertainty, I suppose, but I think is the science is quite sound at this point. So Michael, I'll turn it to you.
Yeah, I think it's completely understandable that people would worry about this, right? But you also have to keep in mind, like, what's the alternative? So your alternative may be getting COVID, and we know that has bad side effects. You talk to some of the people who've had the COVID and they don't feel well for months. And we don't know yet what the long-term effects of that are either. So it's likely that some people are going to have significant symptoms for years after COVID. And we do know that people die from COVID. And so far, people don't seem to be dying from the vaccine.
The experience of most EMS providers, though, is that they don't have much direct contact with critically ill COVID patients. And the pushback that I hear is that I already had it, I was fine, or my coworkers had it, we were all fine, sort of like we'll make it through because we're young and healthy, or I haven't known anyone that's become critically ill or even died, and why should I take a vaccine against something that's not likely to affect me?
So a couple of just clarifications here. I think one is that nobody has died from the vaccine. Okay, I think that's the risk is zero. And again, they've vaccinated now between the Moderna and Pfizer trial 50,000 people with active vaccine. None of those folks have died from the vaccine. So I think that's important. The other thing is to talk about serious adverse events. So these are things like myocardial infarction or stroke, and there is no, the vaccine does not cause any of those adverse events, right? It is just like getting an injection of the placebo of salt water. So in terms of serious adverse health consequences from vaccine, the risk is 0.000, and I can't stress that enough based on the 50,000 people. So I think I take a great deal of comfort in the looking at the numbers and understanding the transparency that's available. And yeah, I agree that on an individual basis, someone could make the argument, well, my risk of getting the disease is relatively low, and then my risk of a bad outcome from COVID-19 is relatively low, but it's not zero. And I think that's important. And I think the other thing that's at issue here is not just individual immunity, but I think community immunity, herd immunity, right? We hear about this concept. And until we achieve herd immunity, we're pretty much relegated to our current way of doing things. And I really think for us to, and to be clear about this is costing lives, right? It's not just COVID deaths, but we see it all over the country that this impacts non-COVID health. And many, many people, whether it's mental health, whether it's physical health, whether it's delaying necessary preventative care, it is costing additional lives. And so we really need, as a society, to get to a level of herd immunity where we can begin to function in a way that enables us to do the kind of work that we always do to provide best care. So I'll stop there. Got to get off the soapbox there. Sorry, Michael.
Dr. Sayre, should I let you keep going, or do you want a couple more questions that have come
go
in
ahead
both
and
through
ask a couple questions. I just want to build on one thing that Tom said, though. So I appreciate, Greg, your point that, people are young. Many people in EMS are pretty young. They're in their 20s. And they're thinking like, well, I'm not very high risk. So, I might as well just get this thing and get it over with. Like, wouldn't that be better?
Yeah.
And I think the data that we have actually suggests that the vaccine will be not only safer for you, but protect you better than actual wild disease. So it seems to produce a more rigorous antibody response than wild disease does. And while we don't have long-term data yet, we do know that, fortunately, only a tiny minority of people get it again, but people have gotten COVID more than once.
Right.
So we'll see. And I don't expect that we're going to find that the vaccine prevents all COVID, because we know it doesn't, but it does seem to prevent the severe cases. And I think, Tom, didn't the Moderna vaccine in particular do an amazing job of preventing severe COVID?
Yeah, so it's a great point, Michael. I do think the immune response to the vaccine does appear to be more robust than to natural illness. Again, time will tell for sure, but I think it's a very encouraging finding. The other thing you point out is that in the Moderna trial, they saw that there were, among the infections, there were 30 cases of severe illness in the placebo arm and 0 cases of severe illness in the real thing arm. So it not only prevents illness, it prevents the most severe illness. And that's a great finding, and I think will really benefit the system because that's the challenge when patients get sick, is the hospitals have to have the capacity to care for them.
I have a question that's come in from the chat, and I've also heard other places that's related to, I guess, who was not included in the trials, for example, children, and then also, my knowledge, women that were pregnant or attempting to become pregnant were not included. And I guess, can you confirm who wasn't included in the trials, and then what advice you might have related to either somebody that's pregnant now or anticipating that in the near future?
Yeah, so I know that they excluded pregnant women from the studies, but some women got pregnant while afterwards. And I know that Pfizer had talked about this with the FDA panel last week, and they're continuing to follow those women to sort of verify whether or not there's any association of getting vaccinated with any kind of issues. Since we know that they also, half of them got placebo, presumably. I don't know that we're going to have better data anytime soon. Maybe Tom knows something else.
No, Michael, you're right. So pregnant women were excluded, but you're right. So there were, I think, about a dozen women who became pregnant during the course of the Pfizer study. My understanding is that sort of the official approach is that the vaccine is going to be made available for pregnant women, that there's no biology that says it would be contraindicated. And in fact, I think the Society for, Obstetrical, the Obstetrical Society is going to come down with an official guideline on what and how to recommend for women who are pregnant. So I think there's more to come on this. Again, the preliminary evidence is that it's safe, but I'm going to wait and see what the Obstetrical Society says.
That seems reasonable.
Right? Yeah, kids were not included in the Moderna study, and I think it was like less than 100 kids in the Pfizer study or something like that. It was pretty small numbers, and so that is an area where there is some debate.
I think the part on the kids is super important. So, both of the companies intend to do studies in teenagers. So we know that children that are older than 10 do have the risk of spreading the disease. The young children seem to have a very low risk of either becoming seriously ill from COVID or being able to spread the disease to others. So I'm not sure when they're going to get a vaccine trial that's focused on that age group. I think the next group they're going after are like these 11 to 17-year-olds.
The top concern we've heard throughout the pandemic is worry about bringing COVID home with them. And it seems to me, like from a risk benefit perspective, that, to help ensure protection for your children or avoidance of illness for your children, vaccination is a pretty important step a parent could take. There's been all sorts of questions, I think, about the trials, and I might just pause a moment to sort of look at the questions that have come in and see if I can't kind of summarize those into one or two questions, and so give you a chance to do some more slides and then interrupt you in a moment.
Yeah, thanks, Greg. I think we talked about the adverse event system and getting the phone app. So I think this point here that, getting a vaccine is going to protect you, protect your coworkers, protect your family and your patients. And those are the reasons to get it. And we know that, I'm blocking my own screen. I can't see here. Sorry. We know that we don't know how long this protection is going to last. So as I mentioned earlier, there's some people that have gotten COVID twice. It seems to be a small number that get symptomatic COVID twice. And that's good news because that suggests that this robust immune response that the vaccine is causing is likely going to lead to substantial protection for years. But how many years is unclear. Is that 1, 2, 5, 10? So we're going to need to measure that and sort of see what happens. And over time, it'll become clear, and then we'll know when to get revaccinated. But I think this is a super important point, that the risk of illness and death from COVID-19 is substantial. It's not like 50%, but it's certainly in the several percent range of severe illness. And for most of us that are on this call, your risk of personal death is less than 1%. But if you're above 80 years old and you get this disease, your risk of death is 20%. So there's a pretty steep ramp up, and we take care of those patients. So I think we have kind of an ethical obligation to protect them from us. And we know that about half, 40% of people spread the disease with no symptoms before they get sick, and they don't know they have it. And so I think it's really, that's a part of creating this herd immunity to sort of stop the pandemic. One more point I think that we need to make is even if you get vaccinated, you're not necessarily completely protected, and you're going to have to continue to wear a mask, maintain the social distancing, and wash your hands, and generally avoid unnecessary contact for a while. Now, I think that in the long run, months, not hopefully years, we can get back to some sort of pre-COVID existence. But one really key question that we don't yet have a great answer to is how much does getting vaccinated really reduce the risk that I'm going to transmit the disease to other people? So because of the biology of this, there's every reason to believe that getting vaccinated will offer substantial protection and reduce the risk that you're contagious, as we've been mentioning, but we don't actually have a clear measure of that. And that is work that's ongoing as well. So I think another question that's come up I saw in the chat, Greg, was about this question about how long it takes to build immunity.
Yeah, correct.
So I'm not sure about the Moderna results, but I know in the Pfizer study, it looked like protection began within a couple of weeks. So even after the first shot, within a couple of weeks, there was a noticeable decline in the risk of exhibiting COVID symptoms and having COVID-19 disease. And by 1 week after the second shot, so basically 4 weeks after the first shot, if people stayed on the schedule, that's really where they had the substantial benefit. So it doesn't take very long to build major immunity against this vaccine. Dr. Ray, is there any data on the Moderna?
Yeah, so Michael, they started sort of formally comparing the two, I think at 2 weeks after the second vaccine. So similar to the Moderna, or similar to the Pfizer. And the challenge, people do ask, well, what if I just got one vaccine? Will I be protected? Well, the reality is, I don't know. There was the start of immune response, early on in those first weeks after the first vaccine, but we really don't know about sort of formal protection because 99% of people went on in the studies to get the second vaccine. So it will be hard to understand just how protective the one vaccine is alone because the studies, everyone got both, essentially.
Yeah, and it may be that it would protect in the short run, right? But it may not have a sustained benefit as much as getting that booster injection.
Now that we're in this mass vaccination phase, will there be any sort of titers drawn or ways to check if people that have received both doses are indeed protected, or are we sort of working on the data from the trials?
That's a great question. I suspect there will be researchers that will definitely study this. And one of the things is sort of talking about the various testing. So if you get your blood drawn for an antibody test and you got vaccinated, you're going to have a positive antibody test, I suspect. Now, there may be some fraction of people that don't make antibodies. So they'll be super interesting to look at and say, well, how come? Why does this person not make antibodies? What's different about their immune response? So that's one thing, but getting a vaccine will not cause you to test positive on a virus test from the nose, because those tests are looking for the viral RNA, and they're not looking for messenger RNA. They're looking for the actual viral RNA that's in the nose. And the vaccine is in your arm, it's not in your nose, and there's no way for that vaccine to make the viral test positive. So if you were to have a test and it's positive from your nose, then you do have a current infection.
Should EMS providers or other healthcare providers that have had known to be infected or think they had COVID, should they either offer to step to the back of the line or use that as a reason they shouldn't get vaccinated, or should they still pursue vaccination at the earliest possible time it's offered to them?
Dr. Ray?
I'll start, Michael. Yeah, and then so I think the short answer is they should get vaccinated, right? So again, as Michael pointed out, the immune response to the vaccine outpaces the natural the response to the natural infection. So I think the short answer is yes, they should get it. They should get immunized. I think there is the option in the CDC guidelines for these folks, if they're within that 90-day window of their natural infection, to consider sort of stepping to sort of the back of their organizational line, if that were something that they could do logistically and reasonably. So that is an option, and to prioritize those people who haven't had the infection. But either way, the goal is that everyone should get vaccinated, regardless of their prior natural history.
A number of people have asked about how many of the trial participants were actually exposed to COVID. And my understanding is it would have been in the course of their daily activities, not a sort of like spray bottle of COVID in their face or something. So was there anything in the FDA and the data presented by the two manufacturers?
So I think there's sort of, I'll jump in first and then let Tom clean up what I mess up here. But my understanding is that, as you said, there was no like spray bottle of COVID, so there was no intentional exposure. And one of the things that was a real challenge for the companies in the early fall was there just wasn't as much COVID out there as they had originally anticipated. So they were having fewer cases. So both studies went looking for people who developed symptoms, and if they developed symptoms, then they got tested with one of these tests in the nose, one of the nucleic acid tests, to see if they had a current infection. So they had to make the trip into the vaccination center, the study coordinating center, and get a test. So that's how they ascertain this. So one of the challenges was they didn't necessarily pick up on people who had maybe very mild infection symptoms or no infection symptoms. So we don't know anything about them because they didn't do surveillance. They only tested people when they were symptomatic. And we do have some sense of the raw numbers, but I don't have them memorized. Maybe Dr. Ray has them in front of him in terms of the number of infections in the two groups.
Dr. Sayre, I have them memorized. Thank you.
Oh, well, it's just one more way in which you're superior being from Michigan.
No, I don't have them memorized. What I can tell you is in the Pfizer study, it was about 160 infections, clinical infections, as you say. They had to have symptoms to get tested. Clinical infections in the placebo group, and only about 8 in the active vaccination. So if you do that ratio, only 5% of the infections occurred in the active vaccination arm. So hence the 95% effectiveness. And the Moderna, similar absolute numbers and almost the exact same ratio. I think it was 94% as opposed to 95%.
Yeah, so we don't really know how many other opportunities they might have had to catch COVID and didn't get it.
I want to switch the direction of the questions more to the messaging to field providers. And as we've done a number of surveys on EMS1 and Fire Rescue 1, and we have an open one on police1.com right now. And I'm kind of seeing the people, there's, I guess, different buckets. One bucket is people, yes, I'm going to get vaccinated. And so I'm not so concerned on this question about them, but more of the other buckets and how you might message to people in these different buckets. So one bucket is people saying, I'm not sure. And then the other buckets are people that have all said no, and I kind of divide them into 3 buckets. One bucket is the unknown side effects, which we've talked about already. The other bucket is people that say no, and they use sort of subjective explanations like this was rushed, or it was political, or it hasn't been transparent, or the research isn't complete. And then the final bucket of no's is people that are, I believe, this is me being subjective, are operating on either misinformation or a lack of knowledge and giving reasons like, I'd prefer natural immunity. It's been a conspiracy. The government will use this to track me. They are misconstruing the facts about the trial, or if vaccines were so easy, how come we don't have a vaccine for HIV/AIDS? So there's been some questions similar to that in the question and answer is like, how would you message the importance of vaccination to these different buckets of field providers?
So I think obviously you have a group of people who are basically can't be convinced. And I hope it's pretty small among the EMS workforce, but I'm sure that exists. And to me, the group that I'm most interested in trying to help are the people who understandably are concerned. They just are a little distrustful of the government, or a little distrustful of the pharmaceutical companies. And I can understand that. I've been distrustful of some of these organizations in the past. And, I think we've all seen examples where maybe we felt like we were misled by some group that we might have trusted otherwise. And I think the best way to get around this is for talking with making sure that if you're in this arm, you're talking to people who are, you use your skepticism, I guess, to in a wise way, and to not just believe everything you're told from another source either. So if you're not believing it from the CDC and you're not believing it from Pfizer, then why would you believe it from some other group? What makes them more credible? And I think that's one way. I think some people are just going to need a little bit of time. They're going to understandably wait. I wish they wouldn't, but I'm sure they will. And they're going to see some of their friends get vaccinated. And then what I predict will happen is they'll then see some of their friends that didn't get vaccinated get sick. And that will help convince many that maybe I watched him, he did great with that vaccine. I watched him and he didn't do so good with the disease. Maybe I should actually go get vaccinated.
I'd be curious if Dr. Ray or Dr. Latimer or any of the other panelists have a response on that question as well.
Well, Greg, I'll start. I'll say that I am I guess I would call myself either a skeptical optimist or an optimistic skeptic. So I think that position is actually quite reasonable. And I think it's right to sort of question convention and question, in a smart way, sort of science and authority. And so to the extent that you can get reliable information from folks that don't have an axe to grind, I think that's the most powerful approach you can take. Again, I will comment that the process to approve these vaccines included this independent group that Michael talked about. They come from all over the US. They have different backgrounds. In fact, lay people, right? People not in science, not in medicine, were on this board that made this recommendation. So they take folks from all different backgrounds. And again, it's that kind of independent collaboration, I think, that really speaks to me. The other thing I would say is, we've got the flu vaccine, we've got the measles vaccine, we've got the polio vaccine, we've got all these vaccines. Never before have I actually reviewed the raw data from these trials. And here I am. I woke up this morning and I saw that the FDA has posted and the ACIP has posted the results in great detail. You can read all 60 pages of the Moderna trial. It's just come on board, and Pfizer did it last week. And so, Google FDA and Moderna results, and it'll pop up. And I invite you to sort of read the whole thing. Information is the most powerful persuader for people who, are critical thinkers. And I know that's what the group here is. So I would encourage folks to take some time. We, Michael and I, and Dr. Kudenchuk and other, Dr. McCoy, have put together sort of frequently asked questions document. Read that and, take it with a grain of salt, and then move on and read another reliable source. And then come back, and if you got questions, ask us, right? Test us, challenge us. And again, I think you'll appreciate that we'll tell you when we don't know something, and there are certainly things that we don't know. But again, I think the weight of benefit versus risk, not just for the individual, but for the community and for the patients we serve, lands squarely on the side of vaccination. So I'll stop there, Greg.
Thanks.
What about
yeah.
either Latimer or Counts weighing in on this question?
I don't have a ton else to add after you both have weighed in there. I think some of what we're seeing is some misinformation that's out there that includes snippets of truth. So some sorts of things that I have seen that people have used to justify avoiding to get the vaccine, or people pointing to published results from, for example, the phase 1 trial that only included a small number of patients and they were all healthy volunteers. And sure, that's the point of a phase 1 trial, right? It's supposed to take a small number of young healthy volunteers to evaluate initial safety. And so I think there's a lot of folks that that get confused, understandably, by the drug approval process, which is complicated. This is not something we consider every day. And so you get snippets of reality from government websites that then get distributed as, oh, this is all that the information that's out there on the vaccine. And so these are the sorts of areas of misinformation that we've been seeing and trying to address. But yeah, I don't have anything else to add.
I'm not going to make a mistake of trying to follow Tom Ray.
One of the things I want to circle back to that's come up in the Q&A is that period after the first dose, and while your body is still building the immune response. Can you still transmit COVID? Can you still give it? What precautions should you be taking? There's been some questions around that.
Just a touch differently. So how about I work Monday and I get my vaccine on Wednesday because I got a couple days off. And now on Thursday morning, I wake up and I feel like crap. Do I need to quarantine and self-isolate? Is this vaccine side effect from administration and it's going to get better? How do we sort of recommend our folks handle that kind of situation? Because that's, I think, what folks are going to experience in the next week and is a really tricky situation.
So I'll take a stab at this and then I'll let Tom weigh in. So I think the University of Washington's infectious disease experts, including Dr. John Lynch, sort of thought about this along with some CDC people. And essentially what they're suggesting is if you get an actual fever, so your temperature is above 100.4 or 38.0, you cannot go to work because you have a fever, because you don't really know yet. Is this just a vaccine side effect fever or is this actual COVID? And their recommendation is if you just got vaccinated 24 to 48 hours ago, odds are high that it'll be a vaccine side effect. So maybe you don't need to run off and get your nose swabbed quite yet, but you should stay home from work if you're scheduled to work that day, and then kind of see how you feel the following day. And if you're basically getting better and all your symptoms are going away, then it's probably the vaccine. If you're not getting better, then maybe you have COVID and you should go get tested. And we've got a version of the flowchart that they are promoting within the University of Washington system. And we'll update our return to work guidance with somehow fit that in there. I'm not sure where it'll fit exactly to try to help people with that decision making.
I want to expand Dr. McCoy's question to the workforce, and presumably with these side effects, if we administered all the CNAs at a skilled nursing facility the vaccine on the same day, there could be no workers the next day. Or if we vaccinated A shift on the same day, in 72 hours when A shift is back, they could be at half their personnel power. So what are you hearing in terms of either hospitals, skilled nursing facilities, or departments in terms of how they're planning the logistics of vaccination so as to not compromise the workforce?
So I think I have a couple thoughts about that, but I'm going to let Tom take this one first.
So Greg, you bring up a reasonable point, which is that you want to be smart about how you implement vaccination. I think a couple things. The first vaccine has a much lower level of sort of these systemic side effects. I think it was 1% got fever with the Pfizer on the first dose, and maybe it's 10 or 12% on the second dose. And so I think we will have a little bit of time to learn here, but nonetheless, yes, some people will feel fatigue, some people will have muscle ache. So ideally, people get it coming off shift when they'll have a few days away from work. That's ideal. And I think the reality is that there may be some advantage to staggering how that happens. I think, for example, the University of Washington is going to let you schedule your appointment. I think public health is likely to do the same thing. And I think that flexibility will enable the different EMS agencies to factor that in, I hope, as they go forward. I'll stop there. I see what Michael.
Yeah, I just want to build on that. So I think a couple things. So one is as an agency lead, I don't actually get to know whether or not you choose to get vaccinated. So we're going to give you, we're working on the process to give lists of names to the places doing the vaccination. So these are people that work for us, and we think they are eligible to be vaccinated. And then it's going to be on the individual to call and schedule their appointment, potentially get their personal health questions answered by the person scheduling them. And all that we're going to get back is you sent us a list of 100 names and 22 of them have now been vaccinated, or 48 of them have now been vaccinated, but we don't know who. Okay. And I think what's going to happen is there'll be some distribution here, and some people will get vaccinated and some won't for a variety of different reasons. And I think we really just got to rely on our workers, our people, to look at their own lives, their own schedules, and encourage them to get vaccinated when they know they're not going to have to work in clinical settings. So that's what I'm doing. I signed up on and I'm going to get vaccinated right before I go on to a shift. I'm pretty sure I'm not going to have any side effects during the next 8 or 10 hours. And I'm not working clinically the couple of days after that. So I'm pretty confident it'll be okay.
Let me make sure I'm not on backup that day.
Yeah, go ahead, McCoy.
I'm going to bounce back to the trials because I think this is relevant. Somebody's asked about just the handling of the vaccine and this importance of temperature and storage and timeliness for administration. That there's, I guess, the possibility for human error throughout that complex process of storage and transport. Was there anything in the trials where either they failed to keep this cold enough or didn't administer it quickly enough that maybe informs how it's going to be rolled out? And then I guess what precautions are happening to make sure we don't waste a bunch of vaccine or give people shots that are, I guess, inactive mRNA, or it's no longer capable of doing what it's supposed to do?
So one of the things that everybody is worried about, this same problem, like we don't want to waste this precious vaccine. We don't want to ruin it by letting it get unfrozen when it's supposed to be frozen. So Pfizer has a whole system built around this. They spent months developing that's got all these temperature trackers they put in the box. They know exactly where the box is. It's got GPS. They know exactly what the temperature is in the box. They know if the box was opened. So they've got all this information about that vaccine. And then once it's delivered to an organization, one of the things that you have to do in Washington is you have to like take pictures of your freezers and submit it to the Department of Health, pictures of your temperature monitoring system and submit that to the Department of Health. So there's pretty robust work been done to make sure that that cold is maintained and that the vaccine does not get the chance to warm up. And I think a good analogy to this is how we handle blood. So we've developed a pretty good system for making sure the blood doesn't get warm. And as EMS has gotten into the business of carrying blood on the aircraft and on ground ambulance, ground medic units, we now know, like, oh, they actually care about this. One of our agencies had this experience. The blood got too cold. and then they had to test it to make sure it was okay. So I think this will be all right. I'm sure there will be some vials that end up spoiling because they didn't get used, and let's hope that is kept to a minimum.
Yeah, the other thing is, you're not going to get negative 90-degree vaccine slugged into your arm, right? This stuff has to get thawed. And then even once it's thawed, if you look at the label, it's good for another week when kept in sort of a temperature controlled refrigerator. So it's not, it's not negative 90 degrees to the patient. It's negative 90 degrees sort of to the vaccine administration place. And then you can give it. So it's, you won't freeze your arm because of this vaccine is the other question I got asked at one point in time this week.
I think it's pretty solid when it's -9. I don't think you could inject it.
Pretty solid.
It'd be a
Those
tough
things
injection.
You can inject anything if you try hard enough.
Dr. Counts warned me that there was a chance that if I kept talking, you all would keep talking. And so maybe this will be my final question, and then I'll step away to let you continue with the rest of your meeting. I know that in Seattle and in Washington, you have a lot of experience rolling out new treatments or improving protocols, I think especially around things like cardiac arrest. And with that experience that you have going into EMS organizations, whether standalone or fire department based, like who are the best people to work with in terms of saying to them, here's something new, we want to implement it, and perhaps it's the experiences you've had over the last 9 months with PPE changes or testing. Who are you suggesting are the best people as influencers, to borrow a term from Instagram, like who are the influencers you want to target in EMS to make sure we get as many of us vaccinated as possible?
Yeah, that's a great question, Greg. So I was on a call yesterday and we were thinking about this exact thing, like who are these influencers? And we're pretty sure that each agency knows who they are. So they're kind of the informal leaders within the organization. They don't have a lot of brass on their shoulders or on their collars, but people look up to them and to ask them, well, what do you think? What are you going to do? And I view them as an important group to message this for us. And one of the things that we're going to do is ask different agencies to identify 1 or 2 people like that, and we're going to get them on video to sort of promote this vaccination strategy that we're developing.
Thanks everyone for this opportunity. I've enjoyed the chance to ask questions and to view the chat and the Q&A. And Dr. Counts, if you need me to keep going, I guess let me know. Otherwise, I'll step aside.
Yeah, I'm going to just say that I want to thank everybody today for being here. There's quite a few other questions that got asked in the Q&A. Most of those are addressed in our frequently asked questions document. So that's going to be distributed by your agencies within King County probably today in many cases. And then that's something we'll update on a regular basis as further sort of questions come in that we need to update. One plug here real quick for the Seattle COVID cohort study. If you're in the area of Seattle and you were in this study and you get sick, they want to see you back. And if you are testing positive, they would still like to have you participate so that they can help work out the immunology of this disease. And then a plug for this podcast I've been listening to that's on, it's a little UK centric, but they have some really good science people on there about vaccination and why we're doing things the way we are, and thinking about how to expand it across the country. So Dr. Ray, you got any final thoughts?
No, I appreciate Greg's involvement. Really, you synthesized the questions, and I think incredibly helpful to keep us on point. So thank you, Greg.
Yeah, I agree.
You're welcome. Glad to be a part of it.